Hi, I'm Brett Beckman, and welcome to the Vet Dental Show. I bring this podcast to you every week on Wednesdays, and as veterinarians and technicians, our goal is to get you to the point where you're super comfortable in your dentistry service so you can provide the best care for your patients. This week, what we're going to do is look at a course that we recently released, and we're going to take a short segment from that course, probably the most impactful little segment that I can pack into about a 12-minute section and give you a preview into that course and also give you an opportunity, if you'd like, to purchase that course at a huge discount just for listening to the podcast. So hang on and we will let you know how to do that at the end of this little segment, and I hope you enjoy it. Let's take a look at some additional diagnostic and treatment decision making that we'll need to employ when we see various fractures in our practice. So this is the first example, and this is super common. This is probably what you're going to run into more often than not. And this is obviously a left fourth upper premolar. We showed this before. And that slab is up underneath the attached gingiva. And fortunately, there's not a lot of inflammation there. And that could definitely be a possible root canal treatment depending on the radiographs. If we take radiographs and there's not a huge amount of lucency around the root tip, then this certainly could be referred for a root canal. Client education at this point. Call the owner and let them know that there's a fracture and that there's a possibility that this could be saved with a root canal, and give them the option to refer. Most of the time, I can tell you in general practice, they are not going to opt to refer. And this, 100% of the time with this tooth, then becomes an extraction. There is no wait and see. There is no do nothing. This is either an extraction or it's a root canal if there is a hole in the pulp cavity. Now, if that hole in the pulp cavity wasn't there, slab fracture is there, and there's no radiographic evidence of non-vitality, then that could be one of the teeth that you can restore, possibly, depending on the extent. This is with that slab off, and you can see, as we always get, there's inflammation under the gum, so that's granulation tissue down in there. There is an edge of enamel that you can see that surrounds mesial and distal where the enamel and dentin meet, and you can actually see a discoloration underneath that thickened margin there where it's a little brown in the dentin, not on the crown, but up next to where the margin of the gingiva is. That is the pulp chamber. And with that being that close, even a root canal would be very unlikely for this tooth. So we need to evaluate that. The problem with that is, in order to shape that tooth, we have to get down into that pulp chamber. That's not going to work. So that would be an extraction. But let's say we don't have that. And let's say that we don't have extension beyond that mucogingival line where those white arrows are pointing to. So we take a periodontal probe and we place it in the defect. It does not go beyond that mucogingival line, then that could possibly be restored. It's a little bit hard to see that mucogingival line there, but in this image of this another tooth fractured in a similar way, you can definitely appreciate that. Right there above all that inflammation, you can see that from the third premolar to the left of that fourth premolar on up, the nice pink, and then you have the alveolar mucosa apical to that. That line of demarcation is the mucogingival line. So if we took that probe in either instance and it went beyond that line, that is an extraction, not a root canal. That's an extraction every time. The other complicating factor, again, if that tooth has a lucency that is significant, then we would probably, as specialists, opt not to do a root canal. Now, this lucency here, if it was only around this one tooth root, does not exclude a root canal. If it's around all three and it's that large, I personally am not going to do a root canal because those are three separate reasons for that to fail. If it's around one, I will give the owner the option and let them know that the chances of that root canal being successful at 93, 94% drop to maybe 75% or less. And most of the time, unless the owner is just truly committed to save that tooth, they are going to want to extract. We take that one step further and look at this tooth, and not only do we have lucencies that are significant around each one of those roots, we also have tooth resorption where that arrow is pointing at that distal root. So that is definitely not a candidate for a root canal. That would be an extraction every day. Doesn't even matter if that tooth is fractured. If you see that radiographically, that tooth has undergone trauma. If it's not fractured, it's non-vital, or that could be a result of periodontal disease as well. Not likely, since it's all three of those roots at the same time. It's almost inevitably going to be endodontic disease, but if you see that in one or two or even three, it could certainly be periodontal disease resulting in those changes. So here's another example. This tooth, if it did not have that open pulp cavity, and believe me, that is open. You can take a Explorer, place in there, and that just drops right into that dark hole. If it did not have that, then that would be something that you would not want to restore. You would want to do odonoplasty and dental bonding. Putting a restoration on there is definitely going to be a failure because that tooth receives too much trauma from chewing and would definitely just slide right off of there after months to years. So that you're setting yourself up for failure if you do any kind of restoration on there, unless it's just a super thin layer of composite. And the only way you would do that is in that instance that I talked about before, if you had near pulp exposure and that was a last resort that the owner gave you that they wanted to try. But that's not your first recommendation. With odonoplasty, you saw in the videos how we use that diamond football burr to clean out that defect and then create our bevel on that restoration site. You'd use the exact same fine diamond tapered burr and just very gently smooth out that enamel, remove the enamel rods, make it smooth with the dentin, and take any unsupported enamel off of there, and then bond that. And you'd want to run that over the dentin as well, making sure that if there's anything that's in that dentin or around that dentin that was left from flower pumice after it's been cleaned, then you have really literally just removed a very small layer of the surface, which sets it up really nicely for your bonding. However, this tooth is another example of what can happen radiographically when we get fractures. So take a look at that. Tremendous amount of resorption present in all three of those roots, which obviously is an extraction, and it's not an easy extraction. So if you're super comfortable with extractions, that would be one that you would definitely experience a challenge on, because if you look at that root that's in the middle there and you look for the periodontal ligament space, you don't see that. So you've got a lot of ankylosis, you've got external resorption, you've got internal resorption, and you've got to get all those roots out of there all the way to the tip. So if you're comfortable with that, great, but most of the time, unless you've been doing this for a while, that would be a referral. This tooth, looking at it from this view, you can see a bulge there right at the mucogingival junction, and that kind of slab doesn't really look like a typical slab. It's just a partial slab, but if you look at it from the coronal aspect, you can see that whole tooth has been split longitudinally, and that is always an indication for extraction. That goes all the way to the bone, and there's no way to save that tooth no matter what you do. This is an example of a fracture as well. And let's say that you did not have that little black hole down there. This would be another potential that you could possibly use your bonding techniques with, your odonoplasty and bonding. Odonoplasty using that diamond taper burr and smoothing out the areas here and possibly on the other side of that dentin after you remove that fragment, getting the debris out of underneath that slab and making that nice and smooth and clean, and then using probably a hemodent or a retraction cord in order to stop the bleeding, in order to keep your field clean so that you don't disrupt your bonding. You have to have a clean, dry field in order to place that bonding agent. It has to stay clean and dry. Retraction cords or hemodent, which is a liquid, can be placed in there and result in hemostasis for you and make that so that you can have a clean field in order to do your odonoplasty and then your subsequent bonding.
That short segment was taken from the composite restoration and bonding course that we launched recently. And as a podcast listener, we'd like you to have a huge discount for that. So if you go to ivdi.org/restore and use the promo code podcast, that'll get you a large discount off of that course just for being a listener on your favorite podcast platform and or on the YouTube channel associated with the podcast. Hope you had a great week. Hope you have a wonderful next week, and we'll see you next Wednesday. Take care.